There we go. Good. I was going to say good morning, but I guess it's afternoon now. Happy New Year to everyone. We didn't have a WPCC meeting, so I didn't see a lot of your faces. So this is the first time in the new year. Since we started, just a little puppy love. This is my new addition. He's 9 weeks old. And I have a baby in the house. Just as I was an empty nester, I decided to get a baby. What was I ever thinking? I wasn't, obviously. So anyway, we're really looking forward to today's LAN. It's going to build off of what we've been doing the last couple homeworks. One thing I do want to remind you as we've been reviewing the homework, the homework that you do in the LAN to advance your work is reportable. So please put that on. Like, I thought I would see more root cause analysis, better understand why our metrics are the way they are. And I don't know that I read it once, but I may have missed it. So please, that's all a part of the improvement work, and report on it, because that's definitely a part of it. So I'm going to go ahead and turn it over to Kathy to kick us off, and let's get started.
Terrific. All right. So today we have a chock full agenda and hopefully some news you can use. We're going to go through measurement first with Tina. She's going to go through some really exciting new, I guess, slides, printouts to share, ways of looking at the data. I think you're going to enjoy that a lot. We always look at your homework. So we are going to talk a little bit about the homework and what we learned, and hopefully hear from you what you learned. And then we're going to move on to today's content, which is really about taking the work that you did with the fishbone and looking at the information and how to choose what to do next. Then we're going to have a chance to think about those, the content that we learned, and talk with each other briefly. And then, as always, we're hoping you'll leave in action, and we'll have our evaluation. So that's our agenda today. And our learning objectives are to first look at the performance on the improvement measures, and Tina's going to work us through that. Then we're going to work through the homework debrief, where all of you did really beautiful fish bones. I will add my kudos to you before Tina gets a chance to, but a really nice job on those. And then, as I mentioned, we're going to give you 4 different options of tools that are useful as you look at your fish bones and try to figure out what next steps to take. And then we'll talk with peers, and faculty will be available should you have any questions about how to apply these. So I want to add my happy 2021. I love this picture because the seat on the beach is empty, and that's how all of us felt when we wished we could be on that beach. And hopefully we'll all be able to go to the beach or our vacation destination of choice. But I do want to just again say what a privilege it is to continue to work with you, and wish you all the best for 2021. So now I'm going to turn it over to Tina, who's going to review our improvement data.
Awesome. Thanks, Kathy. So I am back with another riveting segment on improvement data, and Kathy promised this would be exciting. So I have a high hurdle to get over already. Next slide, Kathy. One more. Just going to skip that for now. Cool. Okay, so this one should be familiar. This is the first required shared quality improvement data indicator, I should say, hemoglobin A1C poor control. So this measures the percentage of patients aged 18 to 75 years of age with diabetes, both type 1 and type 2, whose most recent hemoglobin A1C level is greater than 9% during the measurement year. So right now, what you're looking at is we have 6 observations. So we have 8 teams sharing data from the measurement year ending in July 2020 through 6 teams sharing data from the measurement year ending in December 2020. So as you can see from the number of teams reporting in any given period, there's still some variability in the consistency with which teams are reporting some of their data. And why this is important is it makes the denominator bounce around a lot. Like a little is fine, but a lot can spell trouble for our ability to look at the variation to interpret data. But it is quality improvement data. And for now, what we'll say is that this is still early improvement data. And as your teams are working to reliably and more consistently collect and share that improvement data, we can still talk about the story. There's a lot of story here, and I know a lot of work is happening. So right now, when we look at it, the median for all reported data in each measurement period is 27%. So that means that if we calculate, and I did calculate, the middle value using every month in which teams reported, we have 27% of the population whose hemoglobin A1C is in poor control. So to bring this down to the individual in October, and I picked October because I have 11 teams data, so the most teams data in that one, there was a total population of 9,364 individuals with diabetes aged 18 to 75. And so if 27% are in poor control, that translates to 2,528 individuals. And that there is our improvement opportunity. And that has been the focus of your fishbone diagrams. Let's just take a look at the next slide. So this is where we drill down to the local level. This is what we call small multiples. Basically, it's just all of your run charts for all the teams in the WPCC. It is important to acknowledge that this is quality improvement data. It is imperfect, it is likely to change, and its purpose is for learning and improvement. I'm just gonna ask folks to mute if you're not, if you don't have a question. So the purpose of these is really to help you at the local level look at your own data, but also to help find organizations you can learn from. You might find that another peer organization is doing really well and you'd like to know more about what and how they've achieved that level of performance. So these small multiples, I promised these last month, and you'll be able to see them all in an improvement summary report, which we should have available and uploaded on the portal early next week. And Wendy will let you know when that's there. It'll also include a small snapshot of some of the key themes that we're seeing emerge in some of the narrative that you're reporting. And thank you everyone who has been reporting their narrative. It's super helpful to contextualize the data to help us see what teams are working on, and there's a lot. We can see some early themes like working to understand quality gaps in care processes. Many are organizing patient population health data, working on measurement and monitoring to drive measurement-based care and more. So thanks again for sharing those, and you'll be able to find a bit more detail in the improvement summary. Next slide, please. So another required quality improvement indicator is depression screening and follow-up. And more specifically, I'm going to say this every time, just so we don't make assumptions, we're all on the same page. The percentage of patients aged 12 years and older screened for depression on the date of the encounter using an age-appropriate standardized depression screening tool, and if positive, a follow-up plan documented on the date of the positive screen. I will add that to the slide next time. Again, we have 6 observations. I do wonder if teams are still getting tripped up by the measurement convention. So the convention is that the last month in the measurement year corresponds to the month in the Excel reporting tool. So to give you an example, to be really specific, our last reporting deadline was January 6th. And for that deadline, we were seeking data for the measurement period ending in November. So that means that all data from the measurement year, December 1st, 2019 to November 30th, 2020, would be placed in the November column of your Excel reporting tool. I quite honestly get confused every month. I'm pulling this together. So I made a table to connect all these dots, and that table is available to you guys if you want to copy and paste that into your Excel tools too, to keep it straight. And your practice facilitators can grab that for you if that would be helpful. Again, this is early data. All those caveats apply. Right now, we see a median of 47%. So that means that we have a quality gap of 41%, or roughly in this case, 14,787 people. So the work you've been doing with the fishbone diagram shows some of your theories for why this gap exists, and begins to point to what can we do to close those gaps? What do we know about the cause of this problem, and what level of performance might be possible to achieve by September? So next slide, please. Again, we've got small multiples, all the teams run charts, and a crude emergence of some of the key themes that we're seeing in the narrative reports. Some are working on organizing patient, well, I think almost everyone's working on organizing patient and population health data and measurement and monitoring, which is so foundational to this work. We also see capacity building with working to train staff and the use of PHQ-9s. We see things like using improvement tools to understand gaps, processes, and plan for testing new ways of working. Next slide. And our last required indicator, depressive disorder monitoring. So this is our modified indicator from NQF 0712. It is the proportion of patients with a major depressive disorder who are being screened with a validated instrument every 6 months. So we can see that from the data that has emerged over the past few months, that more and more teams are beginning to measure this, which is a really positive step. I mentioned how foundational that is to this work. And right now, early data caveats apply. The median proportion of patients that are receiving timely depressive disorder monitoring with a validated instrument is 47%. So that means here we have roughly 53% of the population, or roughly 1,900 people, for whom we have a direct opportunity to improve their care. Next slide. Again, we have the small multiples, a lot of variability in this one in what teams are seeing in terms of performance on this measure. A number of teams we can see are really just beginning their processes, and others are starting from different levels, have been doing this for a little while. So this one is probably an area where there is a really strong opportunity for peer sharing to accelerate improvement. So when you get your hands on that improvement summary, take a look at who you might want to reach out to, and this will give you a good sense of what doors you might want to knock on. Next slide. Few more key themes that are coming up from the narrative reports. I just want to give a big kudos to you guys for working through all the challenges in the environment, staff and leadership changes, and the non-stop hurdles of COVID-19. We see things like redistribution of staff and other resources, massively rapid policy and workflow changes. We also see the effects of the vaccine rollout, which is moving staff around. So good for you guys for working through that. Also heard that a lot of you are quite energized to have refreshed and refocused your improvement aims. Lots are gathering and refining your processes for data collection. So really awesome work happening right now. And then the last slide for the data, one more, perfect, is that we, again, just want to point out the measurement convention. If that's an issue for you guys, it's been an issue for me to stay on track with it. Just reach out to your practice facilitator and get help with updating your Excel tracking tool. Seeing lots more teams coming online with data collection and reporting. Small multiples and narratives really tell that story. We have increased understanding of population health status and care processes. Pardon me, my dog just got home from a walk, just busted in. And also, now that many of you have run charts and data, we're beginning to see a clear path to what we need to overcome to drive for improvement by September. I have seen from your narratives, from your charter, really good alignment with the aims you have, the measures you have, and some of the targets that correspond nicely in most cases to what your data is telling you in terms of where you're at. A few of you still don't have some targets, so I would encourage you, now that you have some baseline, to start thinking about what levels of performance do you aspire to by September. Lots of work in measurement and monitoring, which is, again, so foundational to knowing where you are and where you're going. Want to encourage everyone to take a look at the small multiples and the improvement summaries and reach out to help others, and also make sure to reach out to ask people questions. And then finally, I'm seeing this already, but just thought I'd mention, use the tools, use the systematic approach to looking at your data, using the tools like the fishbone diagram. I was so grateful to get to read your fishbone diagrams homework, lots of work happening to help find some of the root causes and diagnose some of the problems and the quality gaps that you're seeing and move forward with next steps, which we'll talk about today. But first, I'll just do a really quick debrief from our homework. So I'll move, perfect. Big thanks to everyone who shared their homework from last month's session. Just as a recap, last month in December, we asked everyone to make 2 fishbone diagrams, one for hemoglobin A1C poor control, and 2 for missed depression screening and follow-up. Again, fishbone diagram is sometimes called a cause and effect diagram. We described it as a tool to help your team brainstorm what are all the root causes to this problem that we're seeing, the problem being poor control or missed depression screening and follow-up. So next slide. This is where I ask you guys, what did you learn from doing this activity? Not all at once. I have to selectively mute you all.
I can go ahead and go. This is Diana with Mid-Valley. I found, since I'm still relatively new to population health, I found the fishbone diagram a little helpful in that it allowed me to dig down just a little bit deeper into the stats and the workflow and looking and kind of evaluating where things were or where they were, maybe earlier last year, since we had a missing population health nurse for most of our metrics last year, and just really where were we at, and being able to take a deeper look at that. So that was pretty helpful.
Cool. And Diana, were you able to engage, how did you engage the team or even?
Not very well. COVID has kind of really slammed us in the holidays, and we had a lot of sick staff out and people working from home. And so it was very difficult actually to get my team together to try to, we kind of did a few emails back and forth, trying to correspond, just trying to get some ideas of what they thought were challenges. And then I just tried to implement or gather the most of what everybody said and throw it in on the diagram.
Great, thanks. Anyone else? Anything surprise you?
I'm with Family Health Centers, and I just want to say that we use the Google Jamboard feature, which is nice because people can remotely be on the same board and write things in, or sticky note them in the case most easiest to use Jamboard. And you can work on it in real time, or you can have someone fill it out if they can't be at that one meeting. So that helps a lot. We do fishbones, like the clinics and staff are fairly used to seeing the fishbones, but we're starting to use it more regularly at all sorts of meetings. Like for example, yesterday, we're trying to problem solve some of the telehealth issues because we had to quickly convert some clinics to telehealth last week. And using that just helps, it just really helps figure out where the problems are, like where you need to start.
Mm-hmm.
Like there can be all these other problems, but if you can't fix the root cause first, fixing the others is just like fixing the symptoms, is not fixing the real thing.
Mm-hmm. Yeah, thanks, Ton. Can you put the link to Jamboard, I think you said, Google Jamboard, into the chat in case folks want to use it?
Yes.
Awesome. And that's one of the reasons why we would use a fishbone too, is it helps look at root causes rather than sometimes we can get stuck talking about symptoms of a problem, right? So thank you for that. Anyone else? Anything that surprised you? How did you involve your team? Obstacles maybe you encountered?
I was really surprised that my team really got into this exercise and were excited about it and all that. I'm like, who knew?
Mm-hmm.
No, they really liked it, thought it was a really valuable tool, really a valuable exercise for us to do that. So yeah, it was pretty cool.
Nice. And that's, having done this with a few other teams too, one of the things I've heard from team members is sometimes you have a loud voice or a really strong interest in the group, and this sort of democratizes the process of analyzing a problem and generating root causes. It gives everyone an opportunity to do it. So just a couple of thoughts. I really appreciate that this isn't a new
Tina?
yeah, go ahead.
Sorry, there was also one in the chat. Comment in the chat from Susie.
Okay,
We saw that there are
yeah.
a lot of factors that impact a patient's outcome, some of which have nothing to do with what is being measured, but directly impact the patient.
Yep, great. Great. And we're kind of going to start talking about what to do about some of those things, right? So I'm also seeing from the narrative reports that some of your teams have shared is that they found it really engaging. Team members got excited or got involved, which is what we heard from Paul. It helps move from talking about symptoms of a problem to its root causes, and gets you driving to solutions rather than just which can be also enjoyable, complaining about the problem, but really helps drive towards solutions. And also, as I mentioned, when staff and when you're able to involve patients, and I've seen teams post sort of just the fishbone diagram in halls. COVID is not a great time to be doing that necessarily, and have patients interact with that board. That can be really helpful to bring in more voices, to bring in the patient voice. It again democratizes the process, brings in, can quash sort of that loudest or most powerful voice, and can avoid one of the pitfalls of improvement, which is the more of the same solution. So if we only had more money, if we had more staff, then we would get out of this problem. So we can overcome that by looking at the root causes. Next slide, please. Some of the observations that I came across in reviewing them is that I found, and you probably found, that some of the causes fit into more than one category, and that is totally okay. So my suggestion is just to do what makes sense to your team, look for consensus on the team, and don't overthink it too much. Number two is that some adjusted the major organizing cause categories, which is great. Again, I really like this approach that you make it your own, you contextualize it, it makes sense for your context. So other organizing categories I saw emerge were workflows. Some teams put the COVID pandemic, other staffing, measurement, and training. So that's another great example of teams using these tools in ways that make sense and add value. I also saw one team adjust the problem statement to better fit their context. Again, great stuff. You really want to make sure that the problems you're addressing are the ones that are important to your staff, and if you're not sure how to decide, use the data. Also, I saw that some teams have a lot of causes and others have only a few, and that's fine too. So the purpose of this tool is really to identify the root causes of a problem, and there's no magic number. The tool helps the team to focus on the problem rather than the symptoms or the history of the problem. And it should create a snapshot of the team's collective knowledge about the problem and be created so that everyone's voice is heard from the team. So if you have a large number of problems that you find when you do this, will they all be, causes to your problem, will they all be significant? Probably not. Will they all be independent of each other? Probably not. Will all the causes contribute equally to causing the problem? Most likely not. And so that's some of the work we're going to do today. What do we do next? How do we decide when we're done? Do all causes contribute equally to causing the problem? Probably not. Do we need to focus on every single one of these causes? Again, probably not. Oh, thank you. And not the best use of resources. So what tools can be used to identify what are the most important causes and how can we work on those first? And there's also probably, you're going to find causes that you can't actually take on. So again, how do we prioritize what causes we start with first? And then of course, what do we start with? So with that, again, thank you everyone for putting that together. I really hope that that has been a helpful exercise, and it sounds like it was. And what we're going to do now, I'm going to hand it over to Kathy, and we're going to take that and we're going to move on to the next steps with it. Kathy, I don't know if you're on mute.
Yeah.
Or if you're just gathering your thoughts.
There we go. Thank you. So yeah, I really enjoyed looking at the fishbone diagrams, and it reminded me just to think about our longer journey of improvement. So this is a really wacky, busy slide, but it really involves the steps in our journey. And you have done a lot of work to date, just thinking about what are you trying to accomplish. And remember when way back when we were talking about the measures and talking about A1C and poor control, we know that there's a system behind that goes on in your site that creates the circumstances and the workflows and all the things that happen with the patient, that how you have it currently designed is giving you a certain number that Tina just showed us on those graphs. So when you identify that that performance isn't what you want it to be, you start your journey. So you identify these opportunities. Maybe you want to improve screening for depression or that A1C. And these are the steps that we've asked you to take. These are quality improvement, evidence-based best practices, and this is what you've been doing. So I thought I'd just show you, you're well along on your journey. So this is great. So you've created your aim statement. You've got your team set up, you're meeting regularly. Many of you are now collecting data on a routine basis. You've set goals for your measures. You're starting to think about impact, like Christina mentioned. You know, each percentage of a person that doesn't get screened for depression isn't just a percentage on your chart. It's a person that you want to serve in a different way. We've asked you to put those things together in a charter, which you've done, which really gives you a handle on the things that your organization is focused on in population health. And next we move to the theory of change. What do you think would make a difference in your system so that you can improve the care that you're currently providing? And we talked about the root cause analysis. We've also in previous calls talked about workflows, and you know, this comes out in what you tell us in the narrative. You're very aware of looking at the way that the work flows through your clinic and who does what and by when. All of those things make a big difference. And because you are looking at these things, you're beginning to gather some data. We're going to talk a lot more about that data today. What we're going to cover really is, if you follow this, I couldn't fit it on one slide, so I had to go round about here, is how do you look at all of those root causes? How do you make sense of what to do first? And today we're going to go through 4 different tools. They're listed there, and I won't say them now because we'll talk about them later. And that's going to give you another idea of where to get started. Or if you're already started, what are some other things that maybe perhaps you haven't tried before that might be helpful to improve performance? And then we ask you to use that methodology that I know you all know and love, that Christina taught you, the PDSA, Plan, Do, Study, Act, and to implement some of those changes. And then now that you're collecting information, you're going to see the impact of the changes that you're making. Is it improving your system the way you thought it would? That's what those blue arrows, those cycled arrows, sometimes you don't get it right the first time. You think that something is really going to make a difference when you try it, and it doesn't move your dots. So we know that there is, it's science, but it's also an art, and it's also persistence that sometimes we have to figure out, because these systems are so complex. We can't always choose one thing to focus on. Sometimes it's more complicated than that. And eventually what we're hoping to see, of course, is that your improvements are achieved, your system improves, and you're really demonstrating that value. This is what value-based care is about, demonstrating the value that your care brings to the patient. So this is all tied into what's happening in your state, and you are very well along the journey. And we're going to come back to this periodically just to remind us that it's a journey, not just a one-time stop. Let me see if I can get my slide to move here. So this was a screenshot from last webinar. I thought it was, I loved it. It was beautiful, but look how busy it is. Look how many ideas you came up with. And that really got us thinking about when you have so many ideas, how do you sort through those? So that's really the content area that we're going to focus on today. And remember that we are looking for the root of the problem. One thing I thought of is now that you have your fishbone diagrams, some of us probably have started down a different road. Some of us get an idea, and often, and again, I'm a physician, so I get blamed for this, probably rightly so, where the loud physician says, this is what we need to do, and you go down a path and you decide you're going to change something. Well, it may not make a difference at all. So what we're really trying to think about is this is an educated hypothesis of where we should focus, but it's not the be all and end all. So if we look at our fishbone diagrams, we want to look at them with a certain lens. So the first thing I think is useful to think about is we want to make sure that any of the causes that we see are aligned with our organizational values. And we also, in part, there should be in your charter, do you have any guidance from your leadership? The most common guidance I hear is, we don't have money to hire staff, so whatever you do, make sure that it's with existing staff. And we also don't have any money to get any new equipment or anything really fancy right now. So make sure any of your solutions to improve this work doesn't involve any major expense. And that's okay. Maybe it's not ideal. If we all had money trees, maybe things would be different, but doing this work in a scientific way helps us discern what are those things that we can make a change about and not worry about those things that are off the table. The other thing I can't emphasize enough is including the people who do the work. So we use the word team a lot, and I want to specify that for the purposes of these tools that we're going to describe, gathering the people that do the work around the measure, the system that you're trying to improve is important. So if you have a quality improvement team, that's great. They can definitely and should have input, but it's really, if you're working on the improving screening for depression care, you really want to involve the people who do that work. If your front desk person is involved in scheduling, whoever does the screening, maybe it's a medical assistant, maybe it's a therapist. You want to involve the people who actually do the work of the system that you want to improve. And we're going to ask you in your homework actually to gather that team and just get a feel, if you haven't done it that way before, just the discipline of getting those multiple opinions and see how it changes your results. It's pretty interesting. And the goal is to work toward consensus. And most of you can achieve that, especially with these goals, these tools that we're going to be sharing. So these are 4 tools. It's not by any means all of them. I'm going to be asking you if you've used these tools before. I bet many of you have, but we're going to go through 4 today: nominal group technique, force field, interrelationship diagram, and a check sheet and a Pareto chart. So we'll get started with those. So the first tool is a nominal group technique. This helps the team come to consensus very quickly. It's really good for teams that are new working with each other, or teams that have dynamics where there are 1 or 2 loud voices and a couple of people that don't say much at all. Although they're thinking, but they just don't talk very much. It is done individually, so you will see how much agreement is with the teams when you look at the tally. So you can see what level of agreement you come into the tool with. And you can also ensure that everybody feels like their voice was heard. Again, that loud voice versus soft voice, it's really helpful to get the buy-in when you want to make changes, when you have come to the decision of what to do by a very equally participatory process. So we're going to go through this. I just want to show you what one looks like, the output, and we'll go through how to do it. So basically, you're going to look on the x-axis. You're going to look at all the members of your team. Again, these are the people that actually do the workflows that involve whatever you're trying to measure, like depression screening. And then you're going to look at all of the root causes that you came out with. And every person is going to be able to determine from their own perspective how important it is to work on that particular cause right now. So let's just go through how to do this. So it's good to have a flip chart. I think most of you do that, or a whiteboard. If you already have done a fishbone, you've done a lot of the work, you can list the major themes that come from that fishbone. You're going to look for duplicates, and you're going to make sure that each person on the team understands each root cause. So sometimes you have to talk those through. We abbreviate those, and maybe it says failed appointment. And some people may interpret that as the patient didn't come to the appointment, or somebody else may interpret it as that the appointment didn't happen, or there was a mix-up in scheduling. So you have to make sure that you understand what each cause really means. And then you just list the problem on the flip chart, the options, and then each team member in private ranks those particular causes in order. So they're all sitting there, they've got a piece of paper, they're going to rank them in order, and then you add them up. And let me show you what that looks like. So I borrowed Moses Lake Community Health's fishbone. Thank you, Moses Lake. And you can see that there's a number of different causes here on their bones. And what I did was I took all of those causes and I listed them. So you can imagine this being on a flip chart. And all of these things are listed. These are things I pulled from the fishbone. I took anything that was duplicated. I only listed it once. I grouped them a little bit so that it says the provider lacks time. Well, there were individual entries about the provider wasn't sure about what medications to use and didn't have time to teach the patient. That there was only a 15-minute appointment, other issues, but the bottom line for that cause was that the provider lacks time. So I organized them in that way. You can do that to make it a little easier on yourself. And then I took it through what I call a feasibility review, which is what we talked about at the beginning. So you may decide that any one of these causes, for whatever reason, is not worth tackling now. So maybe, for instance, think that the patient's lack of understanding of diabetes, you think to yourself, we have all of the resources we can afford right now that's trying to support patients to understand their diabetes. We don't have any more manpower to put that in right now, so we're not going to include that in this particular today to focus on. Or maybe the provider lacks internal staff, like a care manager, a certified diabetes educator, nutritionist. And again, you take that off because your boss has told you there's no money for additional staff. So we're going to cross that one out. Maybe your endocrinologist in the region just left. And so no, there are no timely referral appointments, but you can't get an endocrinologist into the region. So that's really outside of your control. So you're going to knock that one out. And maybe you notice that when you're looking at your diabetes for control, that most of those patients are cared for within your facility. It's not a coordination issue. You know that from your data. So maybe you cross this off. And of course, I'm making all of this up. So you will do this in your team as appropriate. So then you take those causes, you give them each a letter, and then you give your team members around the table or over Zoom, you give them a task and you say, okay, from your perspective, rank these. What do you think is the most important? What do you think is the least important? You give the highest number to the most important, and no, you cannot put 2 twos. You have to rank each one with a different number. And when you do that, you come up with this. So this is what you saw right at the beginning. You see the causes down the y-axis. You see the team members across the x-axis. And the first thing you may notice is that there's a lot of variation in how team members see things. And this is always what happens, is people have different roles. They think things, probably the thing that they do may be the most important, or maybe it's something that they're sure Susie doesn't do a very good job, or Mary doesn't do a very good job, so they're going to rate that one more important. They're each coming from their own perspective. And then all you do is you tally up which one gets the highest number. And in this case, you can see that H got the most number. That means most of the staff on that team think that's the most important. And that particular cause is scheduling challenges for lab and follow-up and future labs. So if that makes sense to the team, then that would be where they would focus. So you take in your root cause diagram with lots and lots of things on it, and you prioritized it. Maybe next they would work on a timely lab process. Oh, I meant to say, I'm just gonna say this out loud because I'm a clinician. The fasting lab, it is true that many patients with diabetes require fasting lab because it's the best way to get some of the lipid parameters. But remember, if you're trying to help a patient with A1C, they do not need to be fasting for that test. So some of us have to jump through hoops to get people fasting, and just keep in mind, if you're just working on the glycemic part, they don't need to be fasting. Anyway, so that's how you do that, particular tool. And what I'd like to know is, if you think about walking through that tool, what do you like about it? Or is there anything you like about it? And this is where you have to talk or chat, please.
This is Stephen. I think I like that it's a tool that you could do remotely. You know, you could have people in various places. It lends itself well to a remote type of meeting because there isn't in-depth discussion and the challenges of doing that remotely. So I like that. Or you do it asynchronously for that matter. You could have people doing it at various times.
Yes, great point, Stephen. Thank you. Anybody else have any comments about the tool? Maybe you didn't like it. You can say that too. That's fair.
This is Dwayne from the center. I think the tool is also curious to see how each person looks at the things you have listed. I'd be curious to find out, like, you know, for somebody, say, who works in this area, this to them is more important versus somebody who works in this area. So I think it's a good way to get an idea of what's important for each person in your agency.
Yeah, you know, we each have our own perspective based on where we are in the system. And it's also true that not all of us understand what our colleagues do day to day. So bringing that perspective of all of the parts of the system really brings this tool home. It really talks about the value of that tool. And then I see,
Kathy?
like that it engages staff members. People always feel good about their job if they help to make a difference. Amen to that. Yes. Yep. Wendy?
I was just going to point out the chat that you saw it, so we're good. And
helps eliminate issues that are completely out of control, giving value to what's within the grasp. Yeah, you know, I spent a lot of years in community health centers, and if you don't have that push to move forward and do what you can fall victim to, oh, we just don't have the money, or we don't have this, or we don't have that. And once you really write it down, there's a lot of difference that you can make. So I really appreciate that comment, Susie. So we're going to do this with each tool, but I just want you to think about, based on the fact that we walked through the tool and you have it in writing in your PowerPoint, which you will have. If you had to use this tool today with your team, how confident are you? Just chat in a number, 0 to 10. 0 is not at all, and 10 is I'm ready to use it tomorrow. Just chat in where you fit. Great. A lot of 8s, that's great. 9 or 10, terrific. Great. Dwayne with the 8.5. All right, like it. All right, terrific. So we're going to move on to the next tool, but keep in mind that we're going to have these here, so you don't have to remember anything. Just let your mind empty, and let's go through the next tool. I really like this tool because it helps you sort through the reasons that you want to make the change and the reasons why it's hard to make the change. And a lot of people get hung up on that because there's always obstacles and benefits of a change. It really helps team members come from both perspectives because they participate in the whole conversation. There's not just one naysayer saying, oh, we can't do that. It's really a conversation, again, by that team who does the work to really have an honest conversation about, does this make sense to tackle or doesn't it? And it doesn't. Even if it's a root cause on your fishbone, it may not make sense to tackle that right now. So really easy to do. You draw a large T on the flip chart, write down the change that you want to think about. You want to write down the ideal state. What if things change the way that you want, if you address this root cause and things look like you wanted them to look, what would that look like? And then on one side, you have the forces that drive you toward making that change. And on the other side, those things that get in the way. And then you're going to prioritize what positive forces can you strengthen. That's one way to get toward the change. Or you can minimize those negative forces. And sometimes, just a hint, sometimes that's the easiest thing to do, is to eliminate some barriers to making the change that also pushes you toward the change in effect. So again, this is, I just took this again from Moses Lake, and I took their fishbone diagram, and I looked at a problem that providers do not optimize medications for patients with diabetes. And there are many reasons for that on the fishbone. And then I wrote that the ideal state was that our clinic provides best practice pharmaceutical care for our patients with diabetes. Again, this is stuff I made up. You may come up with something different even with the same information. And on the left-hand side, we say, well, you know, why do we want to provide best practice? What are the things that drive us toward that? I think mission, you know, value-based care is coming. You know, that providers really want to provide the best care for their patients. The clinic has invested in up-to-date and continuing medical education support so that clinicians can stay current. They want the best outcomes for their patients. They typically want to have good grades, their report card on how they do. That's important. And perhaps you're not meeting benchmarks for incentives that if you were doing better, if your performance was a bit better, you could get some money. So maybe they're the drivers. And then there are reasons why it would be hard to make the change. So we providers are independent. We hate to be told what to do. Sometimes creating a care plan requires some time with the patient, and those 15 minutes just don't allow that. Even if you give the right medication, the patient doesn't take it and there's no support between visits. And you can see each one of these causes. I don't need to read them all, but you can see each of the causes get in the way of actually moving forward with some kind of best practice that is across the clinic. And you may look at this and you say, you know, our mission, and we know value-based care is coming. This is so compelling that we're going to do this and we're going to address this anyway, and we're going to try to minimize some of these barriers. Or you may say, you know what, our clinic director is brand new and we're in the middle of COVID and we just can't see ourselves doing this right now. It looks too hard to us right now. We're going to postpone that. Both of those are reasonable interpretations of this tool. When I look at this as a clinician, I zoom right in the middle, standardized care pathway across the clinic. I know that by creating a standardized care pathway with my clinicians, a lot of those other things would go away. So I might want to tackle that if I feel like I have the time and energy to do so. But again, it gives you a really nice look at the pros and cons. People can have a conversation about what makes sense. So this is another way to prioritize. So that's force field. Anybody see any value in this tool or something that you didn't like about this tool? Just think about driving forces, having conversations about what are the things that are guiding us to do this, make this change, versus things that are in our way. Is that valuable, and if so, why?
It always seems useful to identify the elephant in the room, like this is what's keeping us back from doing this, but this is why we need to, and just putting it out there and getting it on paper, or virtual paper.
Yeah, exactly. I had one team not too long ago, something similar to this, and they were having such a staffing issue that they were afraid to even address the autonomy of a couple of providers in their clinic. They didn't want to rock the boat. And it was like, we're going to do something else. We're not going to forget about this because it's important. But right now, we're not going to rock that boat. So but it's important to have that conversation so that it's not just the elephant. It doesn't remain the elephant of the room. I love that expression. But it's something that you've talked about and you've decided not to do it versus letting it go unspoken. Any other comments about the tool? Do you see any value in it or utility in it, or maybe you have questions about it?
I think, this is Mary Louise Jones from CVCH. I think oftentimes we think of outside forces as immutable and we can't change anything, but this actually says, no, these are forces that you can actually make some, at least a little difference.
Yeah, great point, Mary Louise, thank you. All right, so once again, here comes my little tennis balls are bouncing in, and we're gonna just do confidence. Just a quick confidence check. If you had to use this force field diagram, forces that make it easier, forces that make it more difficult, do you feel like you could manage this with your team? Okay, so we've got a 5. This one's a little lower, okay, overall. And the reason that I'm taking note, I should have mentioned this, we are going to use some of our time in the QI affinity group to narrow in on these tools that you want to learn more about, or maybe you think you understand the tool, but you're not quite sure how to apply it. So we know then to focus on those areas where there may be questions or you're not quite sure what the value is. And thank you, Tina, for putting that in. All right, so let's move on to tool number 3. And I'll warn you that this one is a little busy to look at. But it's really important because I have been with very many people who think deeply about cause and effect. And they may come up with one thing and they say, yeah, but that depends on that, which depends on that, which depends on that. And you go round and round trying to sort through how are we going to get out of this morass of cause and effect. And this really helps us understand the relationships among the critical issues. And as Tina said, a lot of the things in your fishbone are related. You duplicated them perhaps in different bones of your fish. So there are a lot of relationships, but they're hard to visualize in your head. So this tool actually helps you visualize. It also allows you to see things even when you don't have data yet. So if you think something may be more powerful cause and you're not really sure, you don't have data, this may point it out to you. And for those of you who have a lot of things on your fishbone and you're not sure how to simplify it, this tool may well be helpful to you. So to use this, I'm going to call it an ID because it's really hard to say interrelationship diagraph often. So ID, you agree on a problem statement. Again, you assemble that team of people who do the work. You write down each issue on an index card. And then most people I work with put a flip chart paper or table paper on a large conference table. Or if you're remote, you could have somebody do it on a Jamboard or a whiteboard remotely. You write down the issues and then you start with the first issue and compare it with each of the other issues that you have listed. And in each case, you look at one issue and another issue, and you decide which issue influences the other issue more strongly. So if issue A influences B more strongly, you draw an arrow from the index card with A to the index card with B. Then you would look at A versus C, then A versus D. And each time, sometimes the arrow may be pointing toward A, sometimes it may be pointing the other way. And you are not allowed to draw two-headed arrows, which means there is equal influence. You have to make a decision. And that decision can be by consensus. It doesn't have to be vote or anything egregious. Again, this is common sense stuff. Don't get hung up on it. And then you look at the incoming and outgoing arrows for each issue card. And the card with the highest number of outgoing arrows indicates the root cause or driver. And then we'll talk about the incoming arrows in a moment. So I borrowed yet another fishbone. Thank you, Catholic Charities. They also used, they included external factors. You'll see they changed the bones on their fish, which was great. And we just want to look and see how can we take these and organize them and understand their relationships a bit better. So what I did was I took their fishbone and I organized it a little bit. And if you want to see, you could just look at the prior slide. And all I did was I took the same content. There's no content different, but I organized it a little bit. So the first is that the provider didn't offer screening, and it could be that they forgot, or it could be they didn't know how to do it, so they didn't do it in the same way. And the reason that I did that, I was trying to simplify, if I could, the number of different issues that we were trying to understand the relationship. If you have a whole bunch of issues, you can imagine you're going to need a parking lot for your flip chart. So try to simplify if you possibly can before you do this exercise. But here's what it looks like. So I took each of those issues and I mapped them out, make pretend they're index cards, and each issue is lettered. And you can see that there are 8 issues. And then you draw an arrow from which issue influences the other. So for instance, if the provider did not screen, they couldn't document it, that's B. So A influences B. The provider did not screen, client did not keep the appointment. Well, if the client wasn't there, that's going to influence so that the provider couldn't screen. And you go around with each one of these, and you can see I put different colors, but you don't have to do that. I was just trying to be able to see it on the slide here. And so you go around and you create this relationship with all of the issues, and then you count. It's very simple to count the number of arrows going out from the card versus the number of arrows going in. And in this case, once you count all of these up, the number going out was the most that the system failed to send an appointment reminder. And that would be the root cause that you may want to start on, because that particular cause influences more causes than the others. Does that make sense? Okay. The other thing that you can gain from this is if all the arrows point to a particular card, in this case, provider did not screen, that's a really great thing to measure. How many times was an eligible patient not screened? That'll give you a good metric for looking at the impact of your work. If the provider more often screens patients who are eligible, you'll know you're getting somewhere with this piece. But the system failed to send appointment, that may be where you want to start. So again, this is the ID. Pretty straightforward. Again, it's all building off the work that you've already done on your fishbone and trying to figure out where to start. So what do you think about this tool? I know the arrows are a little dizzying to look at. And even I'm watching Mary Louise. She's going, yeah. Tell me what's on your mind, Mary Louise. I love that you're ambivalent about this.
I'm a therapist, so I'm very expressive, but so just, it's really complicated. Again, it shows a complexity, which is not bad, but it doesn't necessarily, I guess it leaves the complexity a little bit, but whew, very busy.
Yeah, it is busy. Anything, and this one seems very complicated. You know, I'm going to ask faculty, has anybody or any of you, has anyone used this ID recently that can speak to a situation where it was really helpful for you?
This is Roger. I think one of the things that it helps point out, and I think you covered this a little bit earlier, is we have a lot of factoids. Often there's a strong voice that believes, well, you know, if we could just get the patients to comply or just get the patients to do this or that, this starts to see that complexity in a slightly different way, and the relationships that actually certain things that we could do are high leverage impact that affect the others, and that helps level that dynamic to a degree. So that's where I found it to be very helpful.
Great, thank you.
Yeah, and I would say that what's really, this tool can be very confusing and lead to interesting conversations. And I think no matter what tool you use, the benefit of it is the conversation that comes out. And with that interrelationship diagram, it often leads to very interesting conversations because you're trying to, in some ways, sequence or add a linearity to the issues, right? And they're not always linear. So it leads to just very good conversations that leads to much better understanding of processes and much better understanding of the problem, and hopefully then the solutions.
Great, thank you. All right, this is the last tool, the Pareto chart. And this is really a cool, very linear looking tool that relies on the 80-20 rule. So 80% of the problems are caused by 20% of the sources. And so this is a Pareto chart that's just a demo, and you can see along the, let me say this, the y-axis on the left is the percentage that each cause accounts for. The percentage on the right is the cumulative percentage. And then along the bottom are all of the possible causes. These would come from your fishbone diagrams. These are all the root causes we think. Now, which one of those root causes might account for most of the system trouble that we're having? It's one way to think about it. So let's dig into this one a little bit. So again, you do much the same thing. You choose the problem, you choose how you're going to look at it, you decide. And I would encourage you, don't measure it for 6 months or a year. Think more like a day or a week. Think small. How long are you going to measure? And you're actually going to count the occurrences, and you're going to vet your hypothesis of what you think is going on by actually gathering data. And you'll be able to see the relative frequency of each of those causes as you evaluate your Pareto chart. So let's just look again at an example. So provider does not screen for depression. Well, again, that could be something that the provider forgets, or he does it and doesn't document it. And if it's not documented, it's not done. So that may be a reason. Or there may be client or system issues. So you're trying to figure out this, the provider is not on record of having screened for depression. What's wrong with this system that is causing this not to happen? Then you allow the teams to collect the data. And I would encourage you to have more than one data collection person so it doesn't fall to everyone. But you agree on how to collect the data, and you do it pretty quickly. And there's also, this is actually a tool. This is a bonus tool, a check sheet. But many of you have done tallies, or you do this in your own way. You collect the data. So this team took all of those causes. They decided that they were going to track all eligible patients who were due for screening for depression. They were going to monitor all of those people eligible Monday through Friday, and they were going to count. And sometimes the provider forgot, and sometimes the client says, I don't want to do that thing. And sometimes maybe there's more than one thing that happened that was a cause in those. And you simply write them down as you see them, and you tally them up, and then you take that information and you create your chart. So there's a nice handy little thing in Excel. It's very easy to use. I can help you. I'm sure Mariah and Wendy can help you. And you just list the number of times that comes out, and then you calculate the percentage each cause accounts for. And then just a tip, when you're doing this in Excel, if you put the percentage next to the cause, it's much easier to make your chart. That's why it's that way, just one step less. And then Excel prints out this chart. It's pretty cool. So it has the causes along the bottom. It has the frequency along the left, the cumulative percentage. And the reason that cumulative percentage is important, if you look across at the 80 mark, you will see that it's really the first 3 problems that account for 80% of the issue in that system. So in this case, it's provider documents incorrectly, the client doesn't come to the appointment, or the screening was due, but it was missed, so it just was never done. So you don't have to focus on these others, the clients who decline, or the provider that forgets, because they're not as frequently occurring. So it really gives you an idea of which of these causes are most likely to give you more bang for the buck. So that's the Pareto chart. So instead of talking about this here, what I'm going to do is I'm going to ask Wendy to open up our breakout sessions, and you're going to have an opportunity to talk with your peers about these tools, get your overall processing. I know it's a lot of information, but just what jumps out at you? What do you think might be useful to you? And just talk a little bit out with your peers. You have about 10 minutes. And you'll be with peers from either behavioral health or primary care. So Wendy, can you open up the breakout sessions?